Hello, everyone, and welcome to our lecture today in our healthcare settings claim cycle and claims processing class. Today's lecture is going to be on the first part of revenue cycle management. Now, you may be asking yourself, what is a revenue cycle? Well, it's a very large process and circle that you all will learn, and it has quite a few processes, but we're not going to go over the entire claim cycle today. So it has to be managed. So what does that mean? A revenue cycle is the process of how a facility takes patient financial and health information, and it goes through and in and out of the healthcare facility and the medical practice. And in the end, the facility or the practice receives reimbursement for the services that they gave to the patient. It includes the physician ordering tests. It includes the patient registration. It includes submitting claims. It includes appealing denials. It includes quite a few things. So there are the steps in the revenue cycle. Um, the patient will schedule an appointment, okay, or the physician will order, like I said, a test or an x-ray or a diagnostic procedure for your patient. And register. So the patient can either register at the front desk or they can register, say, at the diagnostic center. And then you will have the charge capture. So that means that the charge for um, the ordering test or the x-ray or the procedure is put into the system. And so what happens then? Well, we need a diagnosis code, which we talked about, and we need a procedure code, which we talked about, and that has to be put into the system. Everybody, in order to be medically necessary, the procedure and diagnosis has to be determined, and that can only be determined by the physician or the medical clinician who saw the patient. So then what happens? We have the billing and the claims processing, right? You can get a claims that rejection, or you can get claims that are denied, and there's a process that you go through. And then hopefully you can resubmit those claims. Um, and then we have our third party payer reimbursement, and when we get reimbursed, we have to post those reimbursement amounts into our financial system. If we have denials, we might want to appeal them and say, we really think we should still get paid for this procedure, and this is why. Um, Even after the third party payer, which remember that's the insurance company, but we are healthcare professionals and we don't say insurance company, we say third party payer, um, makes the reimbursement, there still may be a residual amount that needs to be paid by the patient, which is probably the co-insurance. Um, there could be self-pay patients. We have to post their reimbursement to us. Then sometimes we have to send bills to collections, and then we have to reimburse, we have to post whatever we get from our collection efforts. So, what is in our management of the revenue cycle? Because it's a large cycle, as you can see, it has to be managed. We have managers that have to take a look at it. We have a whole department that deals with revenue cycle. And when we manage it, it's basically a process that facilities use, they assess it and they help correct their financial situation. It all has to do with finances, the money going in, the money going out. And then part of management is utilization. So we need to make sure we're controlling our costs and we're looking at the quality of care. And what we do is review the appropriateness and the necessity of the patient's care prior to or after they receive their care. So we want to make sure that they're not just getting care just because. We want to make sure the care they receive is quality. And then we also monitor the revenue cycle, right? We have to make sure that we review every one of those steps that we talked about. Okay, we have different standards of measurement, cash flow, different things like that. And then additionally, we have to audit our cash flow. I'm sorry, our revenue cycle, where we audit our cash flow also, so that we can determine if there's areas of poor performance, what they are, and then how can we correct them. Because in order for a facility to stay afloat, they have to have money coming in. So in utilization management, there's some things that are done to try to keep a lid or to try to keep some um, manage how we can manage and make sure things are done in an orderly fashion. So we do what's called a pre-admission certification. So for inpatient care, if the patient is having a surgery or a or a procedure, then the provider's office will ask for a pre-admission certification. So the third party payer will get a form, and it's a request, and it says, "Dear third party payer, um, Miss Blair needs a knee replacement. And this is the reason why, which is the diagnosis. Will you allow this? This is medically necessary." And then a third party payer will say it's approved or it's denied. Now, it doesn't mean they're going to pay for it. It just means we say it's medically necessary. And then you can have the procedure and then you can bill appropriately, and that's when you deal with the money. Okay, then there's pre-authorization. Okay, and then that's where you get the prior approval for reimbursement. Okay, and then you have a concurrent review. So if the patient is in the hospital and they have the need for a particular test, say a CAT scan, very expensive test, or a MRI, which is a very expensive test, okay, where you are put into a very, very large machine and pictures are taken of your insides, because X-rays will only look at your bones, okay, but these CAT scans and MRIs will actually look at your organs and things like that. Well, while you're in the hospital, before they just roll you right in and you get on the table for a CAT scan or MRI, more than likely someone has gotten approval for you to get that particular procedure. And then discharge planning. So if you've had a particularly difficult surgery, then a discharge planner will come to your room and say, okay, do you have help when you get home? Are you going to need home health care services? Are you going to need to have physical therapy? And therefore, they help you to manage your um, home care. What are you going to need? Now, you also have to monitor your revenue cycle. And all of these things are going on at the same time. So it's not like I do this first, then I do this, then I do that. All of these things are going on because you have staff, a large staff, especially in an inpatient setting that takes care of these particular procedures on a daily basis. So you have to measure using particular standards, particular measurements to see how are you doing? How are we doing with our finances? So here's a couple of things that you may hear very frequently. Cash flow, the amount of money that's coming in and the amount of money coming out, going out of a business. Well, we want the amount of money coming in to be more than the amount of money going out. Okay. If the amount of money coming in is less than the amount of money going out, that means that the business is in the red. So they're losing money. Okay. Once again, we want the amount of money coming in to be more than the amount of money going out. And then this is important. The number of days that a particular bill or service, well, we'll say a bill is in accounts receivable. So that means the number of days that that bill is just sitting there and is owed to the facility. And the longer it takes for that bill to get paid, the longer your cash flow is diminishing. So you want the amount of days in the accounts receivable to be a very low number. And a lot of large facilities will have their billers or coders or their quality monitoring staff work on claims that are, say, 60 days old. And they'll say, I want you just to work on these claims. Try to get these claims paid. What's wrong with this claim? Okay. So that they can get that money coming in. Okay. That cash flow is so important. Now, we want to audit our revenue cycle. Okay. Because we want to make sure that we're doing everything we can to make sure our revenue cycle is running smoothly. Remember, we could have 13 steps in our revenue cycle. Okay, so if one of our steps is off kilter, then that affects all the rest of our steps. It's like a domino effect. I don't know if you've ever seen dominoes stacked up, and then a person will push one of them, and all the rest of them will fall down. Same thing with our revenue cycle. So we have an internal audit. So what are we looking for? So we look for compliance, right? And remember, there's also managed care, there's fee for service. I don't think we've gotten there yet, but we're looking for compliance. Compliance means are we doing things within the rules? We look at denials and we look at rejections, and we want to know why are the claims being rejected? Why are they being denied? Denied claims and rejected claims are two different things. And then we want to resubmit them. We want to research them. Like I said before, we look at these claims that have been sitting there for 60 days, coming back and say, what's wrong with them? Let's look at them and see if we can get them resubmitted. Okay. And then once we resubmit a claim, we've got to track it. Have we received reimbursement yet? If not, why not? Let's follow up. There's a lot of following up in the revenue cycle because we need to get the money in. And then we have to post late charges. We have to post, lost charges. We have to post write-offs. There's quite a few things we have to do. We're just skimming the surface. So the beginning of the cycle. When a patient goes to a in the outpatient facility, once they are seen, the information for their diagnosis and their service or services are placed on what's called an encounter form. In the inpatient facility, it's placed on a charge master. It could be called a charge description master. And I'll tell you why it's called a charge description master in a minute. That's the starting point for the coding and the billing. Okay, it's not the beginning of the revenue cycle, but that's where you all come in for coding and billing. Okay, now each facility will create their own encounter form and their own charge master. Okay, it's up to them. Now, it's important that these two documents or systems are reviewed in an ongoing basis to make sure that codes are reported correctly for reimbursement. If you remember, every year CPT and ICD-10 CM codes are revised. They can be deleted. We can have new codes, and therefore, with the facility, they have these committees, and they make sure that codes are updated as necessary. Okay, because you can't bill an old code, it won't go through the system, you won't get paid, and now you're going to have those denials, and it's not going to be very, very good. Okay, so this is what a encounter form looks like, and what it does is it has CPT codes on it, and it also has diagnosis codes on it, and it will have the common CPT and common diagnosis codes for that particular facility or medical office. It will be checked off, and then that is what will be used for the coding. Way back in the day, it used to be called a super bill. Now it's an encounter form. Okay. And then the charge master, it's in the computer, and it has a description of every single CPT code in there. And that's why it's called the charge description. Okay, it has the charge description in the name. And it has to be updated, like I said. Every single particular charge for any department in the hospital has to be in that particular system. Laboratory, X-ray, maternity, ER, oncology, anything, everything has to be in that system. And there's particular codes that are in the charge master. So this is an example of what a charge master may look like. Okay, it's got your service code, the X-ray description, a revenue code, a CPT code, what is going to be charged. I mean, it's just a ton of information in this charge master. But it's needed to bill appropriately. And remember, inpatient billing and coding is different from outpatient. So now we are coding, okay? Now we have to get the claim to the insurance company. I'm sorry, to our third party payer. I wasn't speaking as a healthcare professional, sorry about that. And there's 4 stages to get that claim done. We have to submit it, it has to be processed, it has to be adjudicated, and then it has to be paid. Now, we're going to stop right there because there's a lot that goes into all four of these stages, and I want to be able to spend time on those. So let's wrap it up for this lecture. Okay. I want you to enjoy learning. I enjoy learning new things. Information from today's lecture is in chapter 4. Of course, lecture is always available for you to go back and review it. I know it's a lot of information, but I'm just giving you a summary. The revenue cycle is very important to medical billing and coding. As always, you have to read or listen to our textbook before you submit your assignments, discussions, or assessments. Otherwise, why are you here if you're not going to read and learn? I'm sorry, but that's just the way it is. If you need help, ask for it. There is no embarrassment in doing that, um, because we have all the resources that we think you would need, and we are here for you. Okay. Computer problems, call tech support. I can't help you. Other instructors can't help you. We have the best tech support folks that there are. So please call them up, be specific, and they can help you. So until next time, wrap it up, and I will see you in part 2 of the revenue cycle management.